In the name of God, the Beneficent and Merciful, in this session we are going to have a look to the layers that arrange the scrotum. And as you know, scrotum in the left and right side cover completely the testes and elements that join to the testes. First of all, let's to have a look through the layers that in this picture made a cut through them. The most external layer consists by skin and dartus. You are familiar by dartus. Dartus was a continuous of the superficial fascia that reached to the scrotum and name changed to dartus. For the other layers, when we are going to review the inguinal canal, I told you that in male through the inguinal canal, the testis should be descending and reach to the scrotum. On this way, when each testis is going through the inguinal canal, bring with itself the layers of the inguinal canal. For example, when each testis is going through the superficial ring, when cross the superficial ring, bring with itself a layer that is clear here. This is the external spermatic fascia. It's a layer of the aponeurosis of external oblique. As we expected, external oblique connective tissue that cover the aponeurosis of external oblique. A layer of that come with the testis and made the external spermatic fascia. When I say external spermatic fascia, it means we have another layer that should be internal spermatic fascia. Keep it in your mind. And after this layer, as you see here, is a muscular layer, cremasteric fascia. Why they name this cremasteric fascia? Because a layer is a very thin layer of muscle fibers by connective tissue descending by testis into scrotum. So behind the external oblique, we have internal oblique and transverse abdominis. These muscle fibers originate from the internal oblique or transverse abdominis. So reach to scrotum and join to the layers of scrotum. So under the cremasteric fascia, we reach to another layer, internal spermatic fascia. As I told you, we expected we have this layer. This layer is a continuous of the most internal layer of fascia that we have beyond the transverse abdominis. So I'm sure you understand that it should be a layer of fascia transversalis. So a layer of fascia transversalis made internal spermatic fascia. And of course, you are aware about the most internal connective tissue that we named fascia. We expected we have a layer of peritoneum in scrotum, but it has some detail that I will show you in next picture. But here it's enough that you know that a process of the peritoneum reach to the scrotum and divide into two layers. One of them completely cover each testis and another one join to the wall. When I say wall here, we expected internal spermatic fascia being the side of this bag that the outer layer of peritoneum should join to that. Um, I'm sure that you can remember the peritoneum. When we were discussed about the peritoneum, I mentioned you that a layer of peritoneum attached to the intestine, we say visceral layer, and another one attached to the wall, we say parietal layer. So here it is the same. A layer that attached to the testis, we say visceral layer, tunica vaginalis, visceral layer, and tunica vaginalis, lateral or outer layer, made parietal layer that completely joined to the internal spermatic fascia. So when we dissect the scrotum, it is impossible. We can be separate the internal spermatic fascia from the tunica vaginalis parietal layer. Between the tunica vaginalis, the most internal layer of this bag, between the tunica vaginalis parietal and tunica vaginalis viscera, here there here create a space. Okay, it should be testis, and this one is epididymis, and here inside, I mean the elements that made the spermatocord consist of these elements. This one is vasa differens, okay, and these are the veins that made pampiniform plexus, and this red one under of these plexus or between these plexus is testicular artery. In this picture, uh, you can see by this cut each side, I mean right and left side, spermatocord, and scrotum, and inside of the scrotum. It's a good picture because with this you can see the cremasteric fascia that coming down and cover completely each testis. Then, as you know, genitofemoral is the nerve that supply these muscle fibers. It means if you use something mm, to active these nerves that in some parts innervate the upper part of the thigh, I mean here that I'm show at this part, when you active or made a sense to this nerve, it causes that the cremaster being contracted and bring up the testes. In some cases, it's because of cryptorchidis. It means that testes, because of contraction of these muscles, extra contraction of these muscles, cannot reach to the scrotum and stay in inguinal canal. Here it shows the superficial ring of the inguinal canal, and on the left side, when open this, we face to the fasciospermatic internalis and tunica vaginalis parietal layer. Again, epididymis is clear here, and you can see the testicular artery was a difference that in some cases that is necessary to be infertile or sterile. The male, the surgeon can easily make a cut here, and by two finger, I mean thumb and index, can palpate the vasa difference, because vasa difference made by muscular, very muscular layer that easily can be distinguished and palpate between all of these elements. And again, pampiniform plexus is clear here. In this figure, I want to show you how the tunica vaginalis, a process of the peritoneum, reach to the scrotum. First of all, look to this picture. It shows the skin of the abdomen. I mean, here is the pelvic and umbilicus. You can see here, and this is a sagittal section through the abdomen. So it should be diaphragm here, should diaphragm, posterior wall, and pelvic part, anterior wall. And this one is here, this circle show the peritoneum that made a closed sac in the abdomen. Posterior than this, this one is gonad. In male and female at fetal life, the organs same as testes and ovary named gonad because not differentiated. Each gonad in both sexes attached to the skin at this part that in future this skin is going to make a scrotum or labium major. The connective tissue that they joined the inferior pole of the gonad to the skin of this part is gubernaculum. In next picture, I mean in number 2, as the gonad is going, I mean descend, is trying to descend and reach to the scrotum, a process of the peritoneum, process of peritoneum comes down and fill the inside of the future scrotum. And again, this line is gubernaculum. This process named process vaginalis. So process vaginalis is a process of peritoneum that reached to the scrotum and made a sliding plate for descending of testis. It means it is the descending of testis. In number 3, testis reach to the pelvic part, okay, by contraction through the gubernaculum. Please look and compare this figure number 2 and 3 to each other. In number 2, the duct of this process is open and gradually is closed and completely disappear. In figure number 4, you can see it's completely disappear, and just the part that remain of the process vaginalis completely cover the testis except the posterior wall. Look here, it descend, trying to descend, use this process as a sliding plate, and then when reach here, it's covered by this process, a layer of process that cover the testis. We say tunica vaginalis visceral, and this one that is separate from the visceral we say parietal. So parietal layer is going to find a site to attach firmly. The best layer that is close to parietal layer, it should be the internal spermatic fascia. After birth, I mean when the testis at the time of delivery in month 9, when a child is born, we expected in male that at that time each testis should be in a scrotum, and if you open at that time you cannot find any part of the gubernaculum. But in female, the because the gonad, I mean this change to ovary, not reach to a scrotum because there is not any scrotum in female, but stay at the pelvic. the part the part of the gubernaculum in female change to round ligament and ovary ligament. I will show you in the session of the female reproductive. As I mentioned, at the time of birth, we expected the each testis should be in the scrotum. In the left side, it showed it maybe it need time to completely descend. It may be in some boys they need time for descending testis, and this part is a part of gubernaculum that it should be completely disappear. Mm, please, please attention for descending of testis. Each testis begins to descend during the second month of intrauterine life. It reaches to the iliac fossa by third month and rest on deep inguinal ring at the fourth till 6 months and mm, traverse the inguinal canal during the seventh month, and we expected it reach to the superficial inguinal ring at the month of 8, and it should be at the bottom of the scrotum at the time of birth, I mean the ninth month. Undescended testes found are usually found in 4% of full-term delivered and 33% premature delivers. So, uh, as as we expected, most of these reach to the scrotum within the 3 months of life, and just only 7 0.7% of them remain undescended. And please attention, descent does not occur after 1 year of age. Uh, in female, the most important test at the time of delivery is to check the acetabulum fossa, because the head of the femur should be inserted at the place of acetabulum by flex and abduct the thigh. If it not exactly at the site, it should be easily should treatment started by the leg should be abducted. If the physician do this easily, the acetabulum is created, and in future that girl can easily walk without any problem. Here you can see the arteries that supply the scrotum. Blood supply of the scrotum is by following arteries: superficial external pudendal, deep external pudendal. Look here, this is the femoral artery. It has two branches, superficial and deep, of the external pudendal. Um, and one more branch that to the supply the scrotum is scrotal branches of the internal pudendal and cremasteric branch of inferior epigastric. Look here, inferior epigastric has a branch that is reached to the scrotum. The name is cremasteric branch, and internal pudendal has branches to reach to the scrotum in the name of the scrotal branch. I'm sure you can remember the internal pudendal artery that crosses the Alcock canal and reach to the urogenital triangle. These branches that goes anteriorly reach to the scrotum. Here the mid cut, these arteries, from here reach to the scrotum. These are the posterior scrotal arteries. It's better shown here. Look, internal pudendal reach to the urogenital triangle, and these branches goes directly to supply the scrotum, posterior scrotal branch. In this figure, I try to show you the innervation of the scrotum. As you can see here, the anterior one-third of the scrotum innervate by genitofemoral, genitofemoral, of course, genital branch, and ilioinguinal. I mentioned before that ilioinguinal innervate the base, I mean the root of the penis near to the symphysis of pubic. Here it supply the anterior one-third of the scrotum, and as showed here, the posterior two-third of the scrotum supplied by segment S3 of the spinal cord through the two branches, two nerves, posterior cutaneous nerve of thigh, the preanal branch, and posterior scrota. These two nerves supply the posterior two-thirds of the scrotum. Please attention, the dartus muscle is involuntary and is supplied by sympathetic fiber passing through the genital branch, genitofemoral.